Everyone. Welcome. My name is Rebecca Penn, and I am the project manager for the National Safer Supply Community of Practice. And we're really happy to have you join us today for the program evaluation from Kitchener-Waterloo. I want to start off today in a good way by acknowledging the role of colonialism in our past and our present. We come together in this community of practice from across Turtle Island as people who live on treaty lands and ceded and unceded territories. Our team and community of practice members are comprised of individuals and organizations from across Turtle Island. We're all treaty people. We work in a sector whose goal is to address social and structural harms. We recognize that the production of these harms comes from our colonial history and its enduring practices, institutions, and ways of thinking in our ongoing daily lives. We know that Indigenous people, as well as members of the African, Caribbean, and Black communities, are disproportionately harmed and criminalized by drug policies that are rooted in racism and colonialism. Colonialism is with us today, and we commit to working in ways that transform racist and colonial institutions and practices to repair harms, prevent future harms, and work towards a more inclusive and equitable future. So I'd like to welcome you all here today. For those of you who are members of the National Safer Supply Community Practice, it's great to have you back to another research spotlight webinar. For those of you who are not familiar or who are not members of the community practice, let us just give you a quick overview of who we are and what we do. So we're currently funded by Health Canada's Substance Use and Addictions Program, and we're a collaboration between the London Intercommunity Health Centre, Canadian Association of People Who Use Drugs, Alliance for Healthier Communities, and the Ontario Aboriginal HIV/AIDS Strategy. Our mandate is to support the scale-up of prescribed safer supply programs through capacity building and knowledge exchange. And while our focus is predominantly on the medical model, that is a safer supply that's provided within the relationship between a doctor or between a healthcare provider and a client or patient. We also support non-medicalized models like community compassion club models as well. The medical model that we do support and promote is one that is delivered from a harm reduction and public health approach. I recommend that you check out our website where you'll see the diversity of activities that we do and find a lot of different resources that can help you learn more about safer supply and share information, evidence-based, accurate information about safer supply. So we are recording this event and we will be sharing it on our website. I do suggest that if you are having technical difficulties, the easiest way to deal with it is actually just to log out and log back in. We have closed captioning available in English. We also have the chat feature, the chat box, so you can communicate with everyone through the chat. I do ask that during the presentation, if you have questions that you'd like to pose to our panel, then put your questions in the Q&A box, which you'll find on your toolbar of Zoom. We do have closed captioning available in English, but we don't have French translation. If somebody does need any piece of this available in French, we can organize translation for that. We do have a certificate of attendance. About halfway through the presentation, we'll pop a link so that you can follow that link, fill out the form, and you will be emailed a certificate of attendance. And again, I encourage you to check out our website to learn about other resources, tools, and webinars that we have available for you there. And with that, I'm really happy to be turning this over to Dr. Adrienne Gouda, Dr. Jillian Kola, and Melissa Perry to talk about this the latest evaluation. Thank you.
Thank you so much. Thanks so much, Rebecca, for the introduction and for having us here today. We very much appreciate the space that the National Safer Supply Community of Practice has created for the dissemination of really important evaluation and research like this, and all of the work that you've been doing behind the scenes around this as well. So my name is Jillian Cola. I am one of the people who is doing research and evaluation on the Safer Supply Program in Kitchener-Waterloo. Joining me today are my colleagues, Dr. Adrian Guta from the University of Windsor, where he's an associate professor, and Melissa Perry, who is a PhD candidate at the University of Toronto and doing some research around safer supply as part of her dissertation work. Unfortunately, I am very, very sad to say that Courtney King from Sanguine Health Center, who was supposed to come today to speak with us and be able to answer the program side of the evaluation type of questions, is unable to be here. Courtney has been taken out by the flu. It is that time of the year again, and I feel like I would be very remiss in my responsibilities as a public health person to not emphasize here the importance of vaccination for flu and COVID as we all slowly get taken down at this time of year by increased respiratory infections. But even though Courtney won't be able to join us, we're going to do our best to try to present the results of the evaluation from the Kitchener-Waterloo Safer Supply Program. So there's going to be a couple different parts to this presentation, because for this evaluation, we did something a little bit different. We have the first part where we're presenting the outcomes from the Safer Supply Program using the perspectives of clients and program staff to talk about that. We also have a little bit of information on the collaborative model of care that was developed in Kitchener-Waterloo, which is a little bit unique. And so we'll be presenting that in the second half of the evaluation. And both of the evaluation reports are available on the Community of Practice website. If you're interested in taking a look, we have a longer version as well as a short 4-page summary for everyone to look into. So what we're going to do today is we're going to give you a brief background on the project. We're going to talk a little bit about how we evaluated the program. As I mentioned, we're going to discuss the first report, which is client outcomes after engaging in the Safer Supply Program. And then we will finish by talking about the second report, which is a discussion on the model, the program model that was developed in Kitchener-Waterloo. Now, just to position ourselves and orient ourselves before we even begin, unfortunately, it's always quite important for us to talk about, oh goodness, that went too fast, to talk about the context of the crisis of overdose-related deaths from toxic drug supply, as well as problematic drug policy in our country. And this slide very much illustrates that the problem that we're trying to deal with today in Canada, starting in about 2015, 2016, is a problem of when fentanyl came into the unregulated drug supply in Canada, very rapidly displacing heroin in most parts of the country. Along the bottom, all of those other little colored lines that you see are mostly prescribed opioids. And you can see from data going back to 2003 in Ontario that despite different measures to deprescribe and to taper people off of opioids, we've never actually had very much success at addressing opioid-related deaths that come from prescribed opioids, and they've stayed at very, very low levels compared to the absolute catastrophe that has been the arrival of fentanyl in the unregulated market in Canada, which is that blue line that you see beginning to shoot up in 2016. Pretty much all of the excess deaths that we're seeing right now are due to unregulated fentanyl and fentanyl analogs, as well as more recently unregulated benzodiazepines in the drug supply, with fentanyl making up close to 90% of all deaths in Ontario in 2021. And I like to really start always with this slide to orientate ourselves, because we have to make sure, as we're trying to address the drug toxicity crisis that we're facing right now, that we're really focusing in on the right problem, which is the unregulated drug supply, and just how volatile and dangerous it has become over the last few years. And now it won't move. There we go. I also want to address just from the get-go, because there's been continued questions around whether or not safer supply is in some way related to the increases in mortality from drug toxicity overdoses that we're seeing. And I think it's really important to note from the get-go that this is something that the coroners in both BC and Ontario have been looking at really, really carefully and monitoring quite intensely. And in fact, in Ontario, and this is the chart that you can see on the right side of your screen here, in Ontario, deaths where hydromorphone directly contributed to deaths have actually dropped from 10% in the pre-pandemic period, so prior to 2020, to 5.7% during the pandemic period, which is exactly the period in which Safer Supply was being scaled up in Ontario. So this provides pretty strong signals that Safer Supply is not, in the Ontario context, responsible for any of the increases in drug-related deaths. And you can definitely see at the top there that fentanyl is actually responsible for an increasing proportion of those deaths during this period. Additionally, in BC, the BC coroner has indicated in multiple reports that there's no indication that prescribed Safer Supply is contributing to unregulated drug deaths. And so I just wanted to get this one out of the way right from the very beginning before we even dive into some of the evaluation findings, because we're really in a period right now where there's a lot of misinformation about Safer Supply and prescribed Safer Supply and the programs. What we do, however, have is a mounting body of evidence showing very, very strong outcomes from Safer Supply programs. This is just a collection of some of the different reports, evaluation reports from different programs in Ontario of the Safer Supply programs that have been scaled up. There's also there an evidence review that was done by the Ontario Drug Policy Research Network. I know the National Safer Supply Community of Practice also did a very excellent evidence review. And so it's found, the evidence review from the ODPRN found 15 peer-reviewed published articles on, say, reporting on Safer Supply outcomes since 2020, as well as 5 program evaluations. That was published in July, and there's even more since then. So we're in a very interesting moment where there's these increased amount of research and evaluation on the impacts of Safer Supply programs, not just on what's going well with them, but as well as on some of the challenges that these programs have faced as they have been implemented and scaling up. And today we're going to be talking a little bit about how the findings from Kitchener-Waterloo and the Safer Supply program there really add to this growing evidence base. So next up is going to be Melissa Perry, who is going to talk to us a little bit more about the particular context in Kitchener-Waterloo.
Thanks so much, Jillian. So as mentioned, this evaluation takes place in Kitchener-Waterloo, which some people refer to as a small, big city. And so the work of this program and other harm reduction interventions, which are implemented in similar regions across Canada, are incredibly valuable, given the high levels of substance use related harms that smaller cities like Kitchener-Waterloo face, and the unique forms of harm faced in these regions when compared to larger settings like Toronto, for example. Major issues that are faced within these regions can include limited access to resources, infrastructure, and a lack of broader community support. And all of these factors can actually lead to implementation barriers and adaptation needs that programs like the Safer Supply program face, which we'll hear a little bit more about later on in this presentation. Next slide. So here we have a little bit of an overview of the program model of care, which we'll also speak a little bit more to in a few moments. The Kitchener-Waterloo Safer Supply program is quite unique as it's centered in the Inner City Health Alliance Village of Services. So this Village of Services network is made up of 6 core agencies who all collaborate and provide targeted services for community members who are unhoused or those who are facing precarious housing. So 3 of the 6 core agencies are actually involved in the delivery of the Safer Supply program. And this includes the Working Center, the Sanguine Health Center, and the Kitchener Downtown Community Health Center. And so as you can see on the slide here, each of these organizations provide diverse supports to clients, with the Working Center focusing really on housing and outreach related supports, the Kitchener Downtown Community Health Center focusing on the delivery of primary health care, and then the Sanguine Health Center really being the main organization that houses the Safer Supply program and provides clients with not only prescriptions for Safer Supply, but also broader health and social supports. Next slide, please. So the Kitchener-Waterloo Safer Supply program opened up in 2021 and has made tremendous impact in the community, which we'll hear more about from Jillian in a moment. These numbers that you see on the slide here are really a point in time view of the program, but just for some reference, as of December of 2022, the program supported 150 clients, over half of which identified as cis men and were white. The program held a retention rate of 94%, which is quite high, and as you'll hear about soon, is likely their strong outreach focus. Next slide, please. So today our team will be presenting on the results of a comprehensive evaluation that we've been conducting over the last 2 years. As a formative evaluation, one of the main goals we had was really to provide insights about strengths and challenges of the process of implementing and scaling up a safer supply program in a smaller city that could be used by staff and program operators to iterate on the program and improve it quickly. In this way, successes and challenges being faced could be used as opportunities for improvement by utilizing the important perspectives of clients, internal and external care providers. Next slide, please. So what did we do? So the evaluation of the Safer Supply Program was actually made up of 3 main components. The first 2 components of the evaluation really focused in on assessing outcomes of the program for clients and really understanding the unique aspects of the program model. The third aspect is actually a part of my PhD research and focuses specifically on the role of safer supply in housing and influencing women's sense of security, identity, and aspirations for the future. So although this focus of the presentation today is going to be on the first 2 parts of the evaluation, I just want to flag that we had some incredibly insightful conversations with women and have learned so much about the intersections of gender, housing, and safer supply, which we hope to share in a future community of practice session in the new year. So across the evaluation, semi-structured interviews and demographic surveys were conducted. The first 2 parts of the evaluation also incorporated data from a baseline and 6-month survey, which was led by the program in an attempt to support scale-up. All semi-structured interviews were conducted in person for clients, and those for providers were conducted over Zoom or through phone calls. They were all audio recorded and conducted either by myself or the investigators, Drs. Carol Strike, Jillian Kola, and Adrian Gouda. In the first 2 parts of the evaluation, we spoke with a total of 44 people, split between 22 clients and 22 service providers. And in the third part, I spoke with 20 clients, all who identified as cis women. We used purposive sampling in all parts of the evaluation, with particular attention to capturing a balance of perspectives from peoples of various genders, race, ethnicities, housing experiences, and roles for service providers. Recruitment was done with the incredible support from the staff and took place in the summer and fall of 2022. Data for the first 2 parts of the evaluation were analyzed using thematic analysis in an iterative and collaborative manner. And the third part of the evaluation is taking up a critical narrative analytic strategy with consistent feedback from the research team. Next slide, please. So here's just a little bit of a quick snapshot of the participants we spoke to in the first 2 parts of the evaluation. Most of the clients we spoke with were between the ages of 22 and 40, with just over half identifying as cis men and almost all identifying as white, with a small portion, about 9%, identifying as First Nations, Métis, African, Black, or Caribbean. The 22 service providers that we spoke with were made of both internal providers who worked directly within the Safer Supply Program and external providers who worked in agencies who provided care adjacent to the Safer Supply Program. Most of the providers were also aged between 22 and 40, identified as cis women, and all providers identified as white. So I'm going to flip it back over to Jillian now, who's going to walk us through some of the outcomes of the Safer Supply Program from the perspective of clients and providers.
Thanks so much, Melissa. So I'm going to talk about some of the outcomes from the Safer Supply Program that we identified. Some of these are not going to be terribly shocking because a lot of them are things that we've been hearing consistently from research and evaluation on Safer Supply programs from different teams from across the country. The first and probably most importantly, given that the point of Safer Supply programs is to intervene in the crisis of drug-related overdose deaths that we're seeing across the country, is that both clients and service providers overwhelmingly told us that accessing Safer Supply allowed them to have fewer overdoses and really was responsible for saving people's lives. So as this client mentions that they used to be overdosing quite a bit and they haven't overdosed since being on Safer Supply, which is something quite common that we would hear in the qualitative interviewing with clients. We also have the survey data that Melissa referred to, which allows us to ask people at 2 different time points, at the point at which they were entering into the program, which is the baseline data, as well as in follow-ups that happened at least 6 months after they've been part of the program. And here we also heard very, very similar things from clients. About 33% of clients, when they were coming into the program, reported having experienced an overdose in the past month. This dropped to 4% of current clients, showing a very, very substantial reduction in overdose for people on the program. And when we have just a little bit of a longer look back and we talk to people and ask them about overdoses in the past 6 months, at baseline or program entry, about 60% of people had had an overdose in the 6 months prior to coming into the program, and this dropped to 13% of current clients. So again, we're seeing that very substantial decrease in the experience of overdose after people have received access to a prescribed pharmaceutical of known dose. We also heard from participants that access to safer supply was responsible for reducing their use of fentanyl. And here we hear again that from this participant that they feel that the program saved their life, that they used to do a quite substantial amount of fentanyl, probably about a ball a day of fentanyl, and they're down to maybe half a gram a day. So we're seeing really this really substantial reduction in the amount of fentanyl from the street supply that people are using. It's quite common that people were still continuing to use little bits of fentanyl, sometimes on a daily basis, sometimes having dropped to on a weekly or monthly basis. And there were as well clients who had managed to stop their use of fentanyl as well. And so here we see that 82% of people, when we asked them about their street-acquired fentanyl use, 82% reported having decreased their use of street-acquired fentanyl. About 9% of people reported that their use had stayed the same. 5% had been able to stop completely. And for about 4% of people, which actually, given our sample size, was equivalent to 1 person, their fentanyl use increased after starting the Safer Supply program. We also found that people's access to safer supply was really, they were saying that it was responsible for helping to improve their physical and mental health. People talked about, and you can see this in the quote as well, where the person talks about not being sick anymore and being able to get out, having a bit more energy and the ability to do more activities. So people really found that access to safer supply was responsible for an improvement in their physical and mental health, and in really the stabilization and allowing them to be more involved in their day-to-day activities. We had very similar results in the client survey data, with at baseline about 46% of people reporting that they would rate their health as either poor or very poor. This dropped in the follow-up surveys to 28%. And you see a corresponding movement of people from the okay category. So 28% of people who at baseline self-rated their health as okay. That was up to 43% in the interview, in the follow-up interviews. And we see a small improvement in the number of people who are rating their health as good or excellent in the follow-up period as well. And then we also saw very similar movements in self-reported mental health, where about 46% of people at baseline reported that their mental health was poor or very poor. This drops to 22% among the people who've been in the program for about 6 months. The movement of people who rated their mental health as okay, this went up to 50% in the follow-up data. And the number of people who rated their health as good or excellent, their mental health as good or excellent, went from 22% at baseline up to 28% at follow-up. So once again, we're seeing movements in the right direction when we're asking people about their physical and mental health. And I should just also note here as well that self-reported physical and mental health is actually a pretty good proxy indicator of what people's actual physical and mental health is in different types of evaluations of that as a measure. We also found that safer supply improved access to healthcare. And in fact, this is, I think, one of the really interesting stories about safer supply and prescribed safer supply access. We have been hearing quite a bit from people that prior to being on the safer supply program, people were very disconnected from the healthcare system. People often had report very significant experiences of stigma and discrimination in their past experiences with healthcare providers. And people now that they're on the Safer Supply program, report that they have much improved access to a wide variety of healthcare and social services. So this person is talking about how they're now seeing a psychiatrist because their Safer Supply prescriber helped them with that referral, and that prior to being on this program, they've never had as many community supports as they have right now. I've got the nurse practitioner, I've got a social worker, and it's more like a team management type of thing. So we're really seeing this increased access, not just to the primary care, but also to specialized medical care, as well as to wraparound services and supports. Interestingly, because Sanguine Health Center started out as an organization providing specialized hepatitis C care, here we also had some interesting findings around improved access to treatment and testing for hepatitis C and HIV. This internal service provider talks about how it's really quite easy to start people on Hep C treatment, and that people, when they're coming into this space as Safer Supply program participants, are very open and curious, or looking to find out their diagnosis if they don't already know it. And so really, this is speaking to Safer Supply as a way to really get people involved in other aspects of their health, and accessing treatments that now, luckily for hepatitis C, are really quite straightforward, but some people might not realize that or have access to that prior to the Safer Supply program. Now, we have some interesting results in regards to social determinants of health and the way in which access to Safer Supply was impacting on people's social determinants of health, like income security and housing. This quote is very interesting, because this person is talking about how because they were able to access the Safer Supply program, their consumption of fentanyl from the street supply went down dramatically, that they were using essentially hundreds of dollars a day on fentanyl, and that when the use goes down, the requirement for money goes down, and the behavior to get the money goes down. So here this person is really talking about how the Safer Supply program was able to stabilize and very much decrease their need for fentanyl from the street supply, which meant that they had much less income required in order to meet that need. However, when we asked people on the surveys if they had enough money to pay for their basic needs in the past 6 months, we didn't actually see much change between baseline and in the program for 6 months. I think that this is partly to do with the fact that most program participants are on OW, so Ontario Works, or ODSP, the Ontario Disability Support Program, which has been strongly criticized for having very stagnant rates of support for people, that especially in an environment where with increasing housing costs and groceries just through the roof these days, is making it very difficult for people to be able to meet their basic needs. We did hear a lot, though, from people about how being on Safer Supply was allowing them actually to stabilize and improve their food security. In this quote, this person says, "I've gained weight. I was skinny when I first started. Now I'm starting to be healthy again. I'm eating regularly. I'm trying to take care of myself better, and I'm filling back out my clothes again. So that's great." And so you can really hear how this person is really feeling like their health is improving, and they're having better nutrition because of being part of the Safer Supply program. Unfortunately, we also did find that in terms of food security, there was a drop between baseline and at the 6 months follow-up, where people were finding that they were reporting better levels of food security. However, 53% of people still reporting food insecurity is still a very high number. And again, I think this comes back to the ways in which, we're seeing really huge inflationary pressures on groceries and grocery bills, and very stagnant rates of social assistance. We also heard from participants that Safer Supply was improving people's housing stability, where people were able to access sheltered locations for housing, and then it's such a difference. They're just living with 4 safe walls, a lock on the door, attending their appointments regularly. And so here this internal service provider is really talking about the differences that Safer Supply, when coupled with housing, with secure housing, can really make for people. Unfortunately, again, we still are in a massive affordable housing crisis across Ontario, and in Kitchener-Waterloo, there is no exception, unfortunately. In this client survey data, about 71% of people had experienced homelessness in the past 6 months at program entry. Now, this was able to drop to 49% after being in the Safer Supply Program for about 6 months, which is quite a substantial drop and a very, very strong improvement. And I think here it should be noted, and Adrian's going to speak to this a little bit more in terms of the program model, with having the collaborations across a range of organizations, including the Working Center, which provides quite a bit of the homelessness services and supports within Kitchener-Waterloo. There's quite a focus on being able to get people into both short-term and longer-term housing options. However, it still is very much an uphill battle with a lack of affordable housing across the community. We also heard a lot from people that access to safer supply allowed them to disengage from daily hustles that were necessary to make money. And this quote is really interesting because the person says, before safer supply, we'd run out of money. Maybe halfway through the month, we'd be broke. Now, if we run out of money, it's usually the last week of the month, which is pretty nice, having money in your pocket all the way through for smokes and everything. That's a huge impact. Not every day is consumed with the hustle and the grind of finding money, getting money, finding drugs, doing drugs, start all over again. And we really do hear this quite a bit from folks around how Safer Supply was able to bring a measure of stability in their lives because they were able to take a break from the hustle that was involved in their lives before Safer Supply, and that now they were really kind of like finding a new measure of stability right up until the last week of the month. People also talked about how access to safer supply allowed them to engage in more daily activities and in activities within their communities. And here we have this external service provider who's talking about people, rather than just surviving, when they have a little bit more stability from safer supply, they're able to start thinking down the road, forward-thinking planning and conversations, and just being able to explore other areas of their lives. And so here it's really about opening up the space for people in order to really make their own priorities and plans from having access to a stable supply of prescribed medications. Now, in this presentation so far, we've talked a lot of the successes that the Safer Supply Program has had in terms of reducing overdoses, reducing the amount of fentanyl from the street supply that people are using. However, there's still some pretty strong challenges that were involved, and many of these are actually structural challenges that are beyond the scope of the program itself. As we've just been talking about, there was really, really strong complexities that all of our interview participants raised around housing insecurity and homelessness and the affordable housing crisis that is happening within communities across Ontario. We've heard very, very strongly, and I think that this is a theme that Melissa is going to be talking a lot more about in her dissertation, is that housing stability really affects people's ability to meaningfully engage in the Safer Supply Program, and that the two things together are very, very necessary for people to find stability and to find success. I think that there's always going to be a limit to the ways in which a prescribed medication like Safer Supply, even with the best primary care and social supports, can help people who are being forced to live in encampments because there isn't any affordable housing in communities. And especially, I think this becomes more and more intense as the winter comes on and people are forced to live in really, really much more difficult circumstances. Another one of the challenges that we identified in this evaluation was problems with the variability of the medications offered. And here participants and providers talked about how the ability to access more medication options, so more than just the hydromorphone tablets that are being prescribed, would be really, really helpful to be able to meet a wider variety of different needs. Again, this is something that's very, very difficult, and despite the advocacy that's been happening across the sector to try to increase the availability of medication options on the provincial formulary, we've seen very little movement in that regard in Ontario, which has really impacted programs and their ability to meet people's medication needs. There was also concerns that people raised with us about the continuity of the program, as well as stigma associated with safer supply. Clients voiced this, service providers voiced this around fears about how the program would be able to continue in terms of finding long-term sources of funding, as well as the stigma that they often felt in the community around drug use that has actually been intensifying quite significantly in the last year. People also talked about, we also had some participants who talked about the issue with theft of medications and feeling insecure about that because, like many programs, there is capacity issues where there's many, many more people who need or want access to the Safer Supply Program than this one program can provide. Medications often are actually a valued commodity, and we did hear some people talking about their fears around the theft of medications. I also want to address really, really quickly the challenges around diversion. And this is a question and a conversation that is really in need of nuance at this particular moment. We hear a lot about sharing and selling of medications in the evaluations and the research that we're doing. This report, like many others, reports on it. And here we hear from somebody, one of the external providers, who says, I know that's happening, diversion, even with some of the clients on Safer Supply, but we know that it's going to happen. But overall, Safer Supply is still connecting to healthcare, is still decreasing risk of overdose, decreasing risk of preventable death due to overdose. And I think what's interesting in this quote here is it's really, balancing out the fact that, like many other opioids, like the medications that we use within OAT programs, like methadone and buprenorphine, as well as prescribed opioids for pain, we know that diversion happens within the community. There has always been prescribed medications available for people who seek them out and know how to get them. So they're kind of talking about how that has been a reality for a very, very long time, and then how to balance that with the recognition that Safer Supply is really doing very good things in terms of connecting people to healthcare and decreasing overdose risk. And how do we balance out these really, really strong outcomes from clients with the potential for some diversion within the community, which I think is an important and nuanced conversation to be happening. And unfortunately, many of our conversations around sharing and selling right now are not actually at this level of nuance. We also heard a lot from people about stigma around Safer Supply. We heard both about stigma from healthcare providers within the broader healthcare sector, but we also heard people talking about the stigma from the general community that they felt. And this person said they should know that it's for fentanyl. It's to get off fentanyl. People say to me, oh, now you must have a lot of dope. I'm like, it's not for getting free dope. It's to get off. I don't think they get that. At least the general public, they think it's free dope, and it's not. And so here, I think that this is really, really interesting because this person is really, really talking about the ways in which Safer Supply is often misunderstood at the general public level and what they want people to understand about Safer Supply going forward. So in our evaluation report, just to wrap up and summarize here, some of the areas for growth or development that we identified, the first was in the need to scale up the capacity of the Safer Supply Program. I mentioned before, there was quite a bit more demand for the program than there was places within the program. This capacity issue is very, very common, unfortunately, because the scale up has been quite slow, particularly due to the lack of provincial interest in funding Safer Supply programs, despite the very, very strong evidence base that's been developed over the last 3 years around these programs and the impacts they can have. There's a strong need for sustainable long-term funding for Safer Supply programs. And it's very, very difficult right now to figure out what program's long-term outlook looks like in the current funding environment. There's also a need for expansion of the medication types and the formulations available to clients. Here, I'll emphasize that we did hear from people that there was a need for smokable formulations that wasn't currently available, as we've really seen this transition where an increasing number of people smoke fentanyl. Also, the affordable housing crisis is really going to continue to coming up, and people really, really highlighted the need for safe, accessible, and affordable housing across the sector. There was really a strong need for working across sectors, again, to reduce stigma faced by people who use drugs, as well as people on safer supply, and to ensure continuity of care. Here, this is referring more to ensuring that people who, for example, are hospitalized still have access to the medications that they need to manage their withdrawal and pain within the hospital settings. And we didn't have time to talk about it today, but if you read the report, you'll also see that many of the people that we interviewed talk about the need for broader drug policy changes, including decriminalization of substance use, as well as movement towards non-medicalized safer supply models, because while medicalized models are quite effective at meeting the needs for some people, they're not a panacea, and they're not going to be able to meet the needs of all people who are using drugs for regulated access to a regulated drug supply. And with that, I'm going to turn this over to my colleague, Adrian Gutta, who's going to talk about the collaborative model of care within the Safer Supply Program.
Thank you, Jillian and Melissa. And hi, everyone. Thank you for coming today. I know it's a very busy time of year, and thank you for making time for this. So I'm going to talk about the second report, where we discuss the collaborative sort of village model. And it sort of asks the question, like, how do you organize a village to make it a good place to live, or in this case, to work and to provide and receive services? This is what personally really drew me to participate in this evaluation. I live in a smaller city, sort of comparable to KW. And if you're not aware, any city over 100,000 is considered a large city in Canada. But those of us living in these sort of small, big cities often need to think a bit differently about how to organize and offer services. And so I was really interested in exploring the model. Next, please. So broadly, we heard a lot about the benefits of this collaborative model, right? What can be done across a network of collaborators and partners. It improves accessibility to a diverse village of supports for people receiving safer supply. It enables providers to leverage relationships across a range of services to deliver person-centered and flexible care. It enables continual and appropriate access to primary care for people with complex health and social needs, and much of what Jillian has discussed. Next, please. These are the model elements that were identified sort of through the interviews. So a secure messaging system, provider relationships, a focus on person-centered care, a focus on trauma and violence-informed care, and integrated support. And I'll unpack this, but these were sort of some of the main elements that were identified and are discussed further in the report. And next, please. So participants emphasize the importance of having a secure and real-time way of communicating sort of across the village. And as this external provider explains, generally we become aware of a health issue and then we reach out to our healthcare team through a secure online portal. So, while other programs might have everything in-house and have, a smaller team, providers in the network were able to reach out kind of broadly across the partnering organizations and get advice, engage in consultations, and get a quick response, right? Maybe in this case, no, just get them to a hospital. Since you might ask, the technology that was used is Hypercare, but we're certainly not sponsored by them, and there are many other options. But participants really emphasized how helpful it was to have something like this in place, and of course, that is secure. Next, please. Participants emphasize the importance of leveraging relationships. So relationships within and across teams and organizations. And as this internal provider explains, it's a relationship-based kind of thing. A lot of the folks I work with, my coworkers, have worked with 4 different organizations prior. So they have a lot of these kinds of connections. And, in a smaller big city, you'll also have a smaller health and social service sector. And, you might find that one individual may be initially trained sort of over here, and then they've moved on to another organization, but they still have a really good understanding of what happens at the first organization and has former colleagues there, and, how helpful it is to leverage, those relationships. So we always want to leave on good terms. Next, please. Participants emphasize the importance of person-centered care. And of course, this has come up, in all of these fantastic presentations, right? How much safer supply and person-centered care are linked. And this internal provider explains, someone might come in and not want to address mental health or not think that's the priority. Even if my assessment is different, I think it depends on what they're ready to engage in. And you build trust. And that trust is built through negotiation and compromise and listening to the needs of clients. And my takeaway is that this needs to be a shared commitment kind of across the village model, right? With all of the partners, that you can't have one aspect of the model, sort of one provider that's very directive or prescriptive, because that will become kind of the weak link in the chain. So it has to be a shared commitment to working in this way. And as clients move across aspects of the model, that they feel consistently supported. Next, please. Related to the previous point, participants emphasize the importance of trauma-informed care. And as this internal provider says, I think I try my best to be very trauma-informed with the way I have discussions and lead conversations or follow-ups. And that clients don't have to tell them anything, that they can take breaks, that they don't have to do what might otherwise be considered, routine aspects of a clinical encounter, vital signs, these kinds of things, and understanding that many folks who are receiving safer supply may have very complicated histories with the medical system, with hospitals, with clinicians, even like primary care providers, and that these interactions can be very, very triggering. And again, I think this is something we've heard in most of these evaluations, this approach, which is great. And there have started to be discussions about trauma-informed organizations, and that maybe this can contribute to our understanding of trauma-informed networks. Next, please. All of this kind of supports integrated services, medical and social, with wraparound care, and for some of the most difficult to reach folks, as this internal provider explains. It helps clients who may have had a stronger relationship with another agency prior to meeting us. It can help them to get to our safe supply appointments or other external appointments that they need to get to. And we use this language of kind of difficult to reach, and we sort of all know what it means, but I think Safer Supply has shown us that if you have something meaningful to offer, and if you offer it in a good way, that many people will meet you in the middle, and they do want to avail themselves to various programs or aspects of the program. They become reachable. Next, please. Okay, so some challenges with the collaborative care model were identified. And I do want to mention again that this was a snapshot in time, and the program was new, was getting up and running during a pandemic. And so with any new program, let alone one during a pandemic, there's going to be a learning curve. So and that also much has changed since we collected these data. So some important considerations, kind of clarifying the team of service providers most responsible for program clients. And there were some challenges kind of during the initial transition to a collaborative care model and defining roles and determining who was the most responsible provider for medical care. So if you're thinking about having this great network to tap into and everyone is contributing and sharing ideas, you know, still at the end of the day, kind of needing to know who is the most responsible clinician. Navigating different perspectives among organizations and providers, and recognizing that at least in the early days, not all providers were supportive or as supportive of the Safer Supply Program, and that some of this took time to see how it was going to work. Would anyone benefit? These kinds of questions, and of course, much of this improved in time. Referral and intake processes of the program. And we've heard this from other programs as well, that the intake process was challenging for clients, for a number of reasons. First getting connected, so maybe some expectations around how quickly things would move, and the range of options that were available, kind of versus the reality of titration and things like that. That the requirements were quite onerous at the beginning. There are a lot of health related questions, and again, figuring out how to ask those questions in a sensitive manner. Next, please. Participants also discuss some practical ways of sort of addressing these growing pains, and some I've already alluded to, right? So improving the intake process. It can be made more accessible through kind of insights from a trauma-informed approach. So this might be something as simple as taking breaks during the intake, if necessary, breaking it up across multiple appointments for someone who's really struggling to get through a long appointment. Improving collaboration between internal and external providers, so better communication can lead to improved coordination of care between providers across agencies. And sometimes this is a matter of having that technology in place, learning how to use it better, or figuring out other ways to communicate. And again, I think we all have shared understanding that the last few years have been incredibly challenging to implement a program like this. And then improve communication and coordination between internal and external providers. So formalizing some of the communication processes between staff members at different agencies. And so once you've started to learn about what works, what's helpful, what benefits clients, formalizing that and integrating that into trainings and things like that. Next, please. So these are just some areas for growth and development kind of continued. Strengthen outreach services provided to increase client engagement. So outreach services are crucial and working well. I think this is a very, very important marker of the success of this program, that they've been able to reach folks in encampments. But it will continue to be necessary due to the proportion of clients living in encampments and experiencing displacement due to homelessness and the affordable housing crisis, which Jillian spoke to earlier. And again, I think sometimes in these smaller big cities, these issues are not as well addressed. There might be very, very limited, shelter or alternative housing options. The partnership has done an incredible job of getting some of the clients housed in more emergency style care, short-term and long-term housing, but the options are limited. And at one point during the evaluation, there was a rather large disruption to I believe the one shelter in Kitchener. So an increased support for internal providers. So structured support needed, and unfortunately, and those of you who are in clinical roles, in the service delivery roles, know that often there isn't, unfortunately, there isn't time for structured kind of formal support, debriefing, these kinds of things that can go such a long way to making staff feel safe, and to process things that might have happened. And I'll add, this is especially important for junior staff. Next, please. So reports 1 and 2 are available now, and I believe they will be put on the website soonish. Maybe we can get a confirmation after. And next, please. So as Jillian mentioned, Courtney cannot be with us today, but Courtney is best positioned to kind of discuss the adaptations based on the evaluation fundings. And of course, we had a fabulous kind of feedback loop, where as we were learning, we were sharing it with the clinical and service provider team, and they were making changes along the way. And Courtney was going to speak to that, but I will instead read her notes, or her slide rather. So they've had ongoing refinements to the intake and referral process, and this has involved kind of cross-training across partnering agencies, which is a fantastic way, obviously, to make sure that lessons that are integrated into training are shared with everyone, everyone's on the same page. Acute pathway referral for people at high risk of overdose or experiencing high levels of medical complexity. And we're hearing about the importance, especially of having partnerships with hospitals as well. Clarifying the most responsible provider, so development of a community practice locally, and figuring out collaboration across organizations. So having a shared understanding of who that provider is going to be. And challenges with long-term funding stability. Concerns around deprescribing if funding ends, and high overdose risk for clients if they lose access to prescribed safer supply. And recognizing how much work has gone into programs like this, how tailored they are, how client-centered, how trauma-informed, how quickly lessons are integrated into care, and how incredibly responsive they are. And that the folks who have re-engaged with the healthcare system, in some cases after years, even decades, we've heard in some of the programs, are going to be seriously impacted if programs like this lose their funding. Next slide, please. Okay. So we'll open it up for questions, and Jillian and Melissa are back.
Thanks, Adrian. And I should just note that we really wanted to emphasize here, it's super unfortunate that Courtney has the flu and is unable to be with us today. But if you have any program-specific questions for the team at Sanguine, then Courtney's email is right there. And Courtney indicated that she would be more than happy to receive questions. We will, however, struggle through as well if you have program-related questions, and try to do our best to answer them now. Oh, and there is now a poll on the screen. Rebecca, I'm going to turn that over to you.
Yeah, I didn't realize that was being put up just then, but we do want it to come up now. So yes, while people are putting in any questions that they'd like to ask the panel, you can put that in the question and answer box. And also, while that's happening, take a moment for us and fill out this poll, so that we have some stats to share with our funder, and so that we know how to better tailor these webinars to meet the needs that you have. So yes, thank you, panelists, Melissa, Jillian, and Adrian. We do invite questions in the questions box there. We have one right now. I'll put this out to all of you. Many clients in this space struggle with polysubstance use disorders. It was mentioned that after enrolling in the Safer Supply Program, participants typically have more money in their pocket by the end of the month for smokes, etc. Does the program address smoking cessation, or is that referred out to another service provider? Let's start with that one.
Oh, this is a great example of where it would have been awesome to have Courtney here with us to answer that directly. I am sorry, I do not know the answer to that question. Yes, so I would invite you to directly reach out to Courtney to ask about that. I will say, I'll use this as a jumping off point to just say that I think that polysubstance use right now is very much the norm. That's another one of the major shifts that we have seen in the last few years as fentanyl has come into the unregulated market, along with the move towards smoking fentanyl. There is quite substantial amounts of polysubstance use. I think as people try themselves to kind of, figure out how to balance out both the wanted and unwanted effects of the different drugs and substances within the unregulated drug supply. And so I think that this actually, not just with relation to tobacco, but it really does actually speak with the ways in which providers in this space are having to become more and more familiar and adept with a variety of different substance use related needs. And we really actually, I think, need to turn our attention. We've been very, very focused on opioids and the really tremendous devastation that the unregulated fentanyl supply has been having in terms of overdose deaths and overdose death rates across the country. However, we've been a lot slower to address stimulants. And so I think that that's very much necessary, and in a way that is much more non-stigmatizing than it sometimes gets treated. There's a lot of stigma that still exists around crystal meth in particular. I think that we really need some focuses and some ways to support people who are using stimulants, either because it's their drug of choice or because they're trying to balance out some of the, heavily sedating effects of having benzodiazepines in the fentanyl. And so I think that this is actually an area where we really, really do need to be paying a little bit more attention. So I appreciate that question for that reason, even though I can't address the tobacco cessation part of it, which seemed to be the thrust of the question.
I think what's also great about the Safer Supply programs that, that you've addressed in terms of this model and in many other models or in many other similar programs, is that the goals are always whatever the client's goals are. So if a client does come and say like, hey, I all right, so I've got this going on, now I'm ready to also look at smoking, then I'm certain that there's something happens there for clients. If that was an identified goal, that something, either an internal service would be provided or a referral to another. But yeah, great. So it's really exciting to see the results of this. The outcomes are really, again, they are very promising, and they reflect outcomes from other evaluations that we've had. So that's really, again, those are good, strong signals that we're seeing from these evaluations. It's really exciting for us to have this program model report as well, to see what's really working well, and also in different contexts, right? Like Adrian, you emphasized like the difference between trying to provide services in a small, big city, and leveraging the resources from different organizations. And also, I'm wondering about the sustainability factor there, if there's some additional sustainability that happens when you bring together a partnership like that. Is there anyone who can speak on that? Or again, I recognize that we don't have Courtney here to speak from that internal perspective, but.
Yeah, I don't have a great answer for that. I did want to kind of take a step back to say I think we would also encourage other programs to start to describe their model. I think we're all so excited to hear about the impact on clients, which has been fantastic and is so important, but also in terms of lessons for folks who might be considering, starting a safer supply program. I think this stuff is really helpful, and I've heard as much. Yeah, I guess the flip side of having a fantastic network where everyone's in sort of homeostasis and everything's been figured out across that is, if one or more partners do lose their funding, does it all kind of unravel? Yeah, so then you have to consider the sustainability of all of the partners in terms of sustainability of the partnership. So yeah, that's a really important question, Rebecca.
I think one of the things though that really came out though was the importance in how this trauma-informed approach to providing care is really shifting the culture of care, right? And improving relationships between people who use drugs and healthcare, social care providers. And so, there's some hope in terms of sustainability of that shift in approach.
Yeah.
That comes from a program like this, really investing in that approach and really formalizing that as a key structure to what makes it work.
And I think too, one of the things that's interesting, I'm going to have a bit of a researcher nerd moment here, if you'll excuse me, is that Adrian was talking about the different program models. And I think that one of the interesting things about Safer Supply Scale Up in Canada is that programs look very, very different depending on where you are. We're in this weird situation where federal funding was run directly to programs to scale up Safer Supply, which are, a medical program that should be funded within our provincial healthcare systems because provinces are responsible for delivering healthcare services. Many of the organizations funded, their budgets come from, primarily from the provincial government. To provide these healthcare services within their communities. And this means actually that we've had this interesting situation where based on the province that you're in, the city that you're in, again, here, the big, small city that Adrian was talking about, you get these different models that come up that look a little bit differently. And I mean, I think that as somebody who researches different programs to address health and needs, it's an interesting moment in that we're starting to get some of this data from programs about the different elements of program models that are working well, the different things that have been challenging, the ways in which organizations have come together in order to try to address the challenges that have come up. And I think that that's really valuable information, as Adrian mentioned, when you're looking to do scale up and implementation. You don't have to reinvent the wheel from the get-go. And not only do you not have to reinvent the wheel, you don't actually always have to make the same mistakes that everybody's going to make when you're putting in place a new program, particularly if you're trying to do it during a global pandemic that has brought your healthcare system to practically a standstill, which is the context in which safer supply programs were scaled up in Canada. And so I think that that's a really interesting moment that I hope that we are able to actually have programs move forward in a way that would allow us to get that data on the different program models so we could actually start to do some analysis of this. The other aspect is here, and I'm going to kind of tap Melissa a little bit, is that there is some really interesting findings that are coming out, I think, because we're at the point now, a lot of the initial safer supply evaluations and research was focused on program outcomes and client outcomes. And now that we've got a fair amount of data on that, we're able to pull down into some of the more kind of the more technical aspects. And so, for example, looking at the gendered elements of care and how that might impact for folks, especially people women who've experienced significant trauma, how that might actually impact their care. And so, Rebecca, it's a really nice question. And I think this question of gendered aspects of care is going to be a really interesting one moving forward. And Melissa, I wonder if there's something from your upcoming research that you might have to add around that.
Yeah, I mean, I think that I feel very privileged to be able to have had those conversations with 20 women of the Safer Supply Program. Something that really stands out to me that I often reflect on is the intersecting outcomes for women. For me, and kind of what folks shared is that being on Safer Supply provided women with a sense of stability in a variety of different ways. Not only did it kind of address their immediate pain or withdrawal concerns, but it allowed them to engage in a healthcare system with a sense of agency and a sense of empowerment. They were able to move past a lot of past trauma, both in their personal lives, because they were able to get out of situations that they were staying in, or because of past negative healthcare encounters. So I think that there's lots of kind of gender dimensions of Safer Supply that both kind of get advanced through the provision of the script, but just more so the collaborative nature of actually working with a provider and having a sense of agency in terms of what's important to you, what you want to work on, and what you want to achieve.
And I think that outcome or that experience cannot be emphasized enough. Like, that's such an incredible thing for folks to be able to access care that feels good or feels, like it works for folks. I think that's so important.
And I think what's interesting too is while the sort of internal and external providers within this model were able to reflect on what went well, what didn't go so well, where some of the challenges were, I think, and please, Jillian and Melissa, correct me, mostly from the client end, it was pretty seamless. Like they weren't necessarily impacted by, the learning that was going on, again, in the context of COVID wave after COVID wave, and folks just, trying to stay afloat.
Yeah, I mean, there are just multiple crises that program operators and organizations and frontline workers are operating under such difficult conditions, particularly with organizations that do employ people who use drugs, who are also, like experiencing this in a different way from those who are not. So it's amazing building the plane while flying it and adding on as many passengers as you possibly can, is how lots of people talked about it, and how difficult that is. But also, I also want to make sure that it doesn't sound like it wasn't being done in a very like a very thoughtful and informed way, right? In terms of lots of conversations with folks, like at the community practice, we have program operators meetings where people could pull together, share resources so they don't have to duplicate work, and build on each other's strengths. And like you said, Jillian, have that opportunity to learn lessons from others, so that you don't, repeat creating a challenge or going away that doesn't work as well as it could. So yeah.
And Rebecca, I think
question.
Oh, sorry. I just want to jump on something that Rebecca said, and then we can get to the question. Rebecca, I really appreciate you saying that, because I think that it's important to remember that when everybody was writing their applications for the SUAP funding in 2019, nobody had COVID in their bingo card. People were trying very, very hard to address the massive crisis of overdose-related deaths. And I don't think any of us foresaw either just how bad things were going to get in terms of the acceleration of overdose-related deaths, in terms of the way in which COVID would reveal and accelerate an affordable housing crisis, and would lead to these large encampments in many cities, including in Kitchener-Waterloo, where there's been very active court cases around how to address things like homelessness and encampments. And so I think that we really, really do have to take a step back and really highlight the ingenuity that happened in terms of organizations that were already pivoting 180% in order to try to address COVID and the issues there. Also then we're building safer supply programs, and we're scaling them up and implementing them amidst multiple lockdowns and, everything that we all can remember from that period, amidst, mounting affordable housing crises. And now a little bit of the backlash that's happening as well, where we're seeing this conflation of the impacts of the housing crisis with, substance use challenges within our communities. And so I think it's a really, really interesting moment. There hasn't been a lot of chance to take a step back for us all to reflect. I think these evaluations often are actually kind of nice moments to do a little bit of that work, and also to kind of like realize how much things have moved forward, like Adrian had mentioned, in terms of the collaboration and the ways in which, you know, organizations really did work on the collaboration and the communication, and were troubleshooting how to do things on a very quick and active basis. And so it's very impressive when you go back and look at what has happened and what people managed to accomplish in incredibly difficult circumstances.
I think it's great that you emphasize that, the communication piece and finding the right tools that help people be responsive, flexible, and make those moves quickly. Okay, Michael has a question here. Glad to see impacts on hustle and grind included. Any findings re impacts for participants on crime and victimization? Previous local KW research indicates very high burden.
Mm-hmm. Yes. And thank you for that, Michael. I mean, I feel like you're almost probably better placed to answer that question, because you were the one who did a lot of that very foundational research on, you know, the impacts of crime and victimization for people who were prior to Safer Supply being put in place in the community, and the ways in which and I think we often forget that, especially in this particular moment of such a heavy focus on Safer Supply and questions around whether Safer Supply and other harm reduction interventions are responsible for different, you know, community struggles and community safety issues, broadly speaking. And I think that we often forget that when we were talking to people prior to Safer Supply, people would talk about being the victims of crime and victimization because of their participation in the unregulated market. I like using the term unregulated market for multiple different reasons, but one of them is because it is unregulated. And, you know, so some of the mechanisms that we have in place, you know, for example, if the LCBO shorts you when you're trying to buy, you know, a bottle of wine and they won't give you your change, then there is actual mechanisms in place for us to be able to deal with that. Unregulated markets, that's another place where they actually lack regulation and mechanisms for settling of disputes. And so I think it's important to note that that was like very much people's experience prior to being in Safer Supply programs. And again, here I keep on thinking about how much the capacity issue is just so difficult to tease out. We have never been able to scale up any of our harm reduction interventions, including Safer Supply, to meet the needs within the community. And so you're going to have some people who manage to get access to these programs with very limited capacity. And we heard a little bit about that in terms of kind of like the, you know, the access here and the intake procedures. But that also means that there's a lot of folks who are actually left on the outside and are still at very high need for this intervention without access to it. And so, I mean, that obviously does create quite a bit of an issue. Just to speak to actually answer your questions, you know, again, we spoke a little bit in some of the slides on the outcomes, on the ways in which access to Safer Supply allowed people to remove themselves from the hustle. And we heard that dramatically, like people were really emphasizing that as one of the really strong benefits of being able to access Safer Supply, and that was a really key part of them being able to find stability as defined by them. And so again, I think that it's important to pay attention to some of the inadvertent effects. And so, for example, we did mention and we brought up how some people had raised the fears of victimization because they had Safer Supply prescriptions, and the strategies that they would use, and some of those are actually in the report, the strategies that they would use to try to negotiate that, you know, changing pharmacies and things like that. Pharmacy deliveries here also is another really interesting way of, you know, trying to avert some of the issues that can come about with that. But again, this is a problem of scarcity within, you know, the program can't actually meet the wide variety of needs that are there in the community, or the need for everybody in the community who would like to be able to access Safer Supply. And so you do see some of these issues, as well as some of the ways that people are trying to address them.
But also the structural piece, right? So we get folks Safer Supply, and then if they can get housed, then they can have their prescription delivered. They don't have to go certain places anymore. They can avoid certain people. All of that is great. If there's no housing and somebody is continuing to live in an encampment, they have far fewer options to kind of remove themselves from, scenarios that they might want to avoid. Yeah.
Thanks, Jillian and Adrian. Yeah. There's a question in the chat. How do we deal with stigma and prescribers? I think there's a few different ways to maybe interpret that question, but anyone have any thoughts?
I mean, I just made it. Oh, go.
No, I think you were going to have like the proper answer. I've just been reflecting on the, this wave of stigma, providers who are very open about, their feelings on safer supply, being against it, lots of op-eds, things like this. Melissa is leading, a review of kind of the media response. And if you look back in 2020, there was like a little bit of interest in this, and then kind of nothing happened for like a year and a half, and then now we're being inundated. And it's just been really interesting, to see how, we sort of got this not stigma-free bubble, but this period where it just wasn't on anybody's radar, and now it's, the root of all problems in Canada, supposedly. Yeah. And thank you for the thumbs up as I ramble. I've been reflecting on this and struggling with it.
Yeah.
Jillian, do you now want to give a proper answer to the question?
No, I mean, I don't know that there is a proper answer to this question. And thank you, Sam, for raising this, because I think if we actually knew how to deal with the stigma, both from prescribers within the healthcare system, as well as society more broadly, we would be doing those things. I mean, I think that the issue is that we have long and deep-seated stigmas against people who use drugs based on our 70-year failed experiment with prohibition and the war on drugs. People still seem to see policing people, incarcerating them as, we've really been brought up in this mindset that is, tough love, that's the way to go about addressing this. And I think that Adrian's right. We sometimes see these little moves and interests in ways we can support people and care about people and really listen to their concerns and try to address those. A lot of them within the field of, substance use is actually, motivated by people who use drugs coming together to care for each other within their communities, and then public health very, very slowly afterwards coming along and taking their best ideas and then kind of like medicalizing and public healthizing them. But I think that if we look at the larger history of harm reduction movements, this backlash is very normal. It's happened with every one of our other harm reduction interventions that started from people who use drugs, that was then taken up by public health entities, and that then has, eventually carved out a space for itself. We saw it for needle and syringe distribution programs. We saw it with supervised consumption sites, the point at which it had to go all the way up to the Supreme Court of Canada. Heroin-assisted treatment, spectacular research findings, over 10 years ago in the Canadian context. The failure of our addiction treatment system to scale up heroin-assisted treatment based on the results of those RCTs before fentanyl hit, I think is actually one of our massive public health failures. I've said that before. I worry, I wonder how many of our colleagues and community members would still be alive had we not limited ourselves to one heroin-assisted treatment program for so long. That was because of the stigma, and now we're seeing it again, this backlash again. And at some point, we probably will have to grapple with the ways in which a very small number of voices intent on propagating misinformation are really, really having an outsized influence on the public discourse in this area, how they're overshadowing the now very, very substantial research evidence this from multiple teams in multiple provinces using multiple very strong methodologies. And so I think the problem is that if you, like, you say a lie enough times in a prominent enough setting, then people, do actually start to believe it sometimes. And I think we're actually facing a little bit of that right now. Which is very unfortunate, and unfortunately is probably going to set us back tremendously in terms of addressing the drug toxicity crisis in Canada. And it frankly breaks my heart the way in which this is going to have very, very real impacts on people's lives. It is already having real impacts on people's lives. I think it's very much increasing the amount of stigma that people are facing. And it's going to make it much, much more difficult to actually put in place and scale up and expand the evidence-based programs. And I think that we actually can come to a point right now where we can say that Safer Supply is one of these evidence-based interventions. It still has challenges, but there is a very, outstanding and rapidly emerging evidence base here. This is the question that keeps me up at night, and that frankly, really frustrates me quite a bit. And I'm happy to hear from others if they've got any thoughts on how we can address it, because it's a hard one right now.
Very much so. Very much so. Before we started this webinar today, the group of us here were talking about where to, what note to end on. And here we are minutes away from closing the webinar today. And that's a really heavy note to end on, Jillian. And it's very much the reality of where we're at. And this also keeps me up at night, as I'm sure it does all the people on this call. I am really grateful for the community that we do have of people who are out there doing the research, providing the services, fighting for good policy change and making this work happen. And grateful that we have this increasing, like you said, this increasing body of evidence to demonstrate how important it is to have safer supply as one of the tools on that continuum of care for people who use drugs. And we need that whole continuum of care to be bolstered with proper funding and infused with a trauma-informed approach and all of that, so that we can use all of those tools and all of the doors can be open to people. And so we continue, and I'm really grateful that we have this evaluation report, these reports to add to our collection of evidence that anyone can find on our website. I also invite folks to let us know if you need any help with pulling evidence together, or looking for ways to share accurate evidence-based information with members of your community. Please feel free to reach out to the community of practice. I know the others on this call are also willing to participate in helping support people get good information out there. So with that, let me say a big thanks to, well, first of all, Melissa, Jillian, Adrian, did you have anything else you'd wanted to add before we close off for today?
No, you did a pretty good job of bringing us back around. I've been in the doom and gloom space lately, so I really do appreciate, Rebecca, you bringing us back to that, because I think it's really, really necessary in these times. And thank you, all of you here at the Community of Practice too, for providing this space and for all the work that you're doing around this. It's very much appreciated as well. And I see lots of other thanks in the chat here too as well. All right then, everyone. Wishing you all well and sending all my thanks. Melissa, Jillian, Adrian, and Courtney in Courtney's absence. I'm really grateful for the work you do and what you've contributed here. Thank you.